Anorectal mass on colonoscopy. Well, now, it's Friday afternoon and your endoscopy practice is just getting ready to close down. The last patient of the day, Mr. Andrew Andrews, is already here and your mind is already getting ready for the weekend. You pull out his chart and start reviewing. He came into his PCP's office with a complaint of fatigue, and it appears he has iron deficiency anemia to boot. Go figure. The astute PCP ordered a colonoscopy, which is why you got brought into the picture. Minimal medical history, no family history. Mr. Andrews arrives with his husband, Peter, who you recognize from the pre-op visit. You get all set and start to intubate the rectum. But your skilled hands have difficulty. It seems there's something blocking the scope. You take a look and there's a mass right between the rectum and the anus. You biopsy it, then call your pal at the pathology office for a quick read. He gives you an unheard of turnaround time of about 10 minutes. He says that it's malignant squamous cell carcinoma. Well, shoot. It's time to go break some bad news to Peter while Andrew is waking up from the mild sedation. What's the best next step for this patient? Well, I think we have some little friends coming in to help us answer that question. It's the polypettes. You may remember them from our colon cancer sketch series. Like, colon cancer? It doesn't quite sound like it. But, maybe this is rectal cancer. While rectal carcinomas and colon cancer have a lot in common, so much so that they're often referred to together as colorectal cancer, this sketch is going to focus on rectal cancer only, with the key similarities and differences highlighted. Primary rectal adenocarcinomas are a common large bowel malignancy, making up about 30% of all diagnosed colorectal cancers per year. While primary squamous cell carcinomas of the colon and rectum are possible, they're exceedingly rare, and nearly all primary rectal cancers are adenocarcinomas. Well, there you go. Mr. Andrews from our clinical case probably doesn't have rectal cancer. I was wrong, okay? But since we're on the topic, let's chat a bit about rectal carcinoma. Rectal carcinomas cause signs and symptoms almost identical to other left-sided colorectal carcinomas, including bleeding, usually bright red blood, which can lead to iron deficiency anemia, abdominal pain, constipation, and changes in stool caliber, pancakey or ropey stools. In case it hasn't become painstakingly obvious yet, any older patient with rectal bleeding or unexplained anemia should undergo colonoscopy to rule out colorectal cancer. I mean, with our clinical case, we gotta give some credit to the PCP. They astutely ordered a colonoscopy on their patient with unexplained iron deficiency anemia. Colonoscopy is also used as a screening exam for colorectal cancer. It can provide a tissue diagnosis or even be therapeutic in some cases. If a small rectal carcinoma is confined to a polyp, polypectomy may be treatment enough as long as several stringent criteria are met. For more on polypectomy as treatment for early large bowel cancers, check out the Polypet colon cancer screening mushroom harvest sketch. Remember that from our clinical case, the biopsy revealed squamous cell carcinoma. However, in the case of rectal cancer, once colonoscopy has given us a tissue diagnosis of rectal adenocarcinoma, the next step is to evaluate the extent of disease, aka staging. As with colon cancers, rectal adenocarcinomas are staged using the TNM system. Patients diagnosed with invasive rectal carcinoma should undergo contrast CT of the chest, abdomen, and pelvis to look for metastases and get a framework for surgical planning. Unlike colon cancer, in which CT imaging is enough for local staging, rectal cancers are staged locally with pelvic MRI. This is because pelvic MRI provides much more detail about local invasion, especially in the tightly packed pelvic tissue planes. For smaller, more accessible tumors, transrectal ultrasound actually provides even more accurate information regarding local invasion than MRI, though it may not be feasible in all cases, especially with large tumors. As with colon cancers, preoperative serum carcinoembryonic antigen, CEA, levels are measured for prognostic information and postoperative surveillance, not diagnosis. After colonoscopy and preoperative workup, rectal adenocarcinomas are staged using the exact same TNM categories as colon adenocarcinomas. Briefly, T is for primary tissue invasion, not size. N is for nodal involvement, which, if present, automatically makes the cancer stage 3, And M is for metastasis, which, if present, automatically makes the cancer stage 4. For more details on colorectal TNM staging, check out the colon cancer sketch. It's important to talk about venous drainage of the rectum, because this impacts how rectal adenocarcinoma behaves. The vasculature of the rectum is divided between the systemic, caval, and portal systems and is a test question favorite. The venous drainage of the upper 2/3 of the rectum is via the superior rectal veins, which continue on to the inferior mesenteric and portal veins. This means the upper 2/3 of the rectum drains into the liver along with the rest of the proximal colon, making liver metastases most common. The lymphatic drainage from this region of the rectum follows the superior rectal arteries, branches of inferior mesenteric artery, which lead to the para-aortic lymph nodes. The distal 1/3 of the rectum, however, drains into the middle and inferior rectal veins, internal iliac veins, and eventually, the inferior vena cava. The first organ that this venous drainage has the chance to bring metastases to are the lungs, which is why lower rectal cancers have a higher chance for lung metastasis. Lymph drainage from here follows the middle rectal and internal iliac arteries, which involves the internal iliac nodes. It's important to note that for T3 or T4 locally advanced rectal tumors, or for rectal cancer with node-positive disease, neoadjuvant chemotherapy and radiation should be performed. Neoadjuvant, of course, means before surgery. Patients have been shown to have large benefits from this. So much so that sometimes the cancer is gone after pathologic evaluation of surgical specimens. There are lots of implications regarding this that are being researched currently. Accepting what we just said, currently, the only accepted truly curative treatment for rectal cancer is surgical excision. Just like with colon cancer, many of the same surgical principles even apply as well, such as taking the main arterial vessel at its origin and removing at least 12 lymph nodes for pathologic examination. However, the proximity of the lower rectum to the anal canal and anal sphincter, as well as the circumferential tissue surrounding it, makes resection here a little more complicated. For upper rectal cancers, excision of the primary tumor with a 5 cm distal margin can be performed while sparing the anal sphincter, i.e., sphincter sparing procedure. This is symbolized by this rectal-looking worm being removed without removing the apple core. The classic operation performed is the low anterior resection, or LAR, which involves removal of the affected colon, mesentery, lymph nodes, and superior rectal artery pedicle. A colorectal, colon to distal rectum, or coloanal, colon to anus anastomosis is performed, with a colorectal anastomosis preferred due to its lower rate of incontinence following surgery. While tumors of the upper rectum are easy to excise with the standard 5 cm margins, this gets a little trickier as you get closer to the levator ani and the anal sphincter complex. Remember that the levator ani is the division of the rectum and anus and the anal sphincter. Distal resection margins in the lower rectum are different for those of the upper rectum and colon. Why? If the standard 5 cm margins were used for all lower rectal cancers, the anal sphincter would be removed every time, leading to incontinence. To strike a balance between preserving the anal sphincter while also ensuring a good cancer resection, distal rectal cancer should be resected with at least 2 cm margins above the levator ani. If the tumor can't be removed with at least a 2 cm margin from the levator ani, an abdominoperineal resection is performed, which is a big operation. From an abdominal incision, the entire rectum, along with the little sigmoid, is dissected down to the levator ani. From a perineal incision, the anal canal is dissected up to the levator. In the end, APR involves removal of the entire distal sigmoid, entire rectum, and entire anal canal. A permanent colostomy is placed, and the perineal incision is closed primarily. You can see this symbolized by the polypet preparing to cut out the very sphincter-appearing core of this apple. As with colon cancers, CEA levels are obtained every 3 to 6 months following resection of a rectal adenocarcinoma, with colonoscopy performed at 6 to 12-month intervals as well. That pretty much sums up rectal cancer. Keep an eye on those key differences between colon cancer and rectal cancer. Well, that was informative, but not related to our patient Mr. Andrews from our clinical case. And I'm certainly glad about that. I'd hate to subject him to such a severe surgery like an APR. Let's talk about other cancers that may give us the answer to our clinical case. Moving southbound from the colon and rectum comes the anal canal, which is quite different from the rest of the GI tract. Since the anal canal has a different histology, malignancy here is a little different as well. Most cancers of the anal canal are actually squamous cell carcinomas, not adenocarcinomas. Now we're on to something. Remember the biopsy from the clinical case? Mr. Andrews has squamous cell carcinoma. Let's keep going. HPV infection, especially when genital warts are present and active, is a huge risk factor for development of anal cancer. Well, that doesn't add anything to our clinical case. The incidence of anal cancer is higher in females, though it becomes even higher in men with HPV and genital warts who have receptive intercourse with other men. Sound familiar? And in people with HIV infection. And lastly, smoking increases risk of anal cancer, just like it makes everything else worse too. So don't smoke, kids. So let's think back to our clinical case. Smoking? Men having sex with men? This is starting to fit with our clinical case. A word on histology. Anal cancers rising above the dentate line, symbolized here by the wiggly line around the water, are non-keratinizing squamous cell carcinomas. You may be thinking, but that's where the intestinal epithelium is, so it should be adenocarcinoma. True. But remember that there's a transitional zone above the dentate line where the histology transitions from intestinal epithelium to squamous epithelium, and where squamous cell carcinoma is the prevailing malignancy. Carcinomas arising below the dentate line are keratinizing squamous cell carcinomas. Squamous cell carcinoma that develops in the anal margin, i.e., where the skin has hair, is referred to as perianal squamous cell carcinoma. And finally, while they are rare, adenocarcinomas may form from the glandular elements of the anal canal. Since they behave exactly like the adenocarcinoma of the rest of the colon and rectum, they are treated the same way. In any case, the most common presenting symptom of patients with anal cancer is mild rectal bleeding. Well, Mr. Andrews didn't mention hematochezia during our clinical case, but he does have iron deficiency anemia. So maybe he just doesn't look at the toilet paper after he wipes. They may also complain of a sensation of fullness or pain in the anal rectal region, as well as tenesmus, which is a feeling of always needing to have a bowel movement. Sort of like urinary frequency and urgency, but for your anus. And I'm not talking about the planet. Or am I? Yeah, I'm not. The first step in diagnosis of anal cancer is, not surprisingly, biopsy of the suspicious tissue, which can be accomplished with simple anoscopy. With the diagnosis in hand, the next step is staging. We've biopsied, and for workup, we need to do some more for Mr. Andrews from our clinical case. But remember that the question asked what the next step in treatment is. Endoscopic ultrasound is a useful method for closely examining the anorectal walls and surrounding structures. A 360-degree ultrasound view can show normal wall destruction by tumor, tumor characteristics, and invasion into surrounding tissues. Staging of anal cancers also follows the TNM system, which requires a chest CT to look for metastasis in the lungs, abdominal and pelvic MRI to evaluate the primary tumor and look for METs, and PET CT to really hunt down the METs. And while we're on METs, remember lymphatic drainage of the anal canal above the dentate line is typically to the internal iliac nodes, while drainage below is usually to the inguinal nodes. Metastasis may spread hematogenously as well. Above the dentate line, the anal canal drains venous blood into the superior rectal veins, which lead to the inferior mesenteric and portal veins, which means liver metastasis. Below the dentate line, the anal canal drains venous blood into the inferior and middle rectal veins, which lead to the internal iliac veins and vena cava. If a tumor seeds along this path, it can hitch a ride to the IVC, right heart, and eventually right into the lungs. Bummer. And with that, we can move on to treatment. And here's where we'll find our answer from Mr. Andrews. Given anal cancer is so different from the rest of the GI cancers, it should come as no surprise that treatment is different too. The mainstay of treatment for anal cancers is actually chemotherapy and radiation, not surgery. The protocol used is called the Nigro protocol and has been around since the 70s, although recently there have been modifications made. In fact, chemoradiotherapy is so effective that surgery, in the form of an APR, is a last-line treatment used in patients only with remaining therapy-resistant disease following aggressive chemoradiotherapy or in patients with recurrent disease. So hopefully Mr. Andrews does well with the chemotherapy and radiation and gets spared a surgery. All right, let's summarize. The vast majority of rectal cancers are adenocarcinomas. Signs and symptoms of rectal carcinoma are similar to those of left-sided colon cancer. These include hematochezia and iron deficiency anemia, abdominal pain, stool caliber changes, and constipation. Colonoscopy should be performed for these symptoms or for unexplained iron deficiency anemia. Biopsy can give tissue diagnosis, and if the carcinoma is contained to a polyp, may provide definitive treatment as well. Once tissue diagnosis is made of invasive rectal carcinoma, the patient should undergo staging with CT of chest, abdomen, and pelvis, pelvic MRI for local staging, and rectal ultrasound. CEA should be obtained before treatment for surveillance following treatment as well as for prognosis. Rectal adenocarcinoma is staged per the same TNM staging that colon cancer uses. Remember that the upper 2/3 of the rectal venous drainage goes into the portal system, making the liver the most common site of metastasis from tumors in this location. For the lower 1/3 of the rectum, the venous drainage goes directly to the systemic or caval system, and this makes tumors in this location more likely to cause metastasis to the lungs. Neoadjuvant chemotherapy is standard of care for patients with T3 or T4 tumors, or for patients with nodal positive disease. However, surgery is still required. As with colon cancer, at least 12 nodes should be removed with the specimen for accurate pathological staging. The more common procedure is a low anterior resection, removing the affected part of the colon and rectum and performing a colorectal or coloanal anastomosis. Typically, upper rectal tumors are still able to have 5 centimeters of distal margin without compromising the anal sphincter complex and risking incontinence. However, lower rectal cancers may not have that much room. For this reason, distal margins of 2 centimeters are adequate for surgical resection. If a 2 centimeter margin can't be performed, then the patient requires an abdominoperineal resection. This involves transabdominally removing the entire rectum and performing a permanent encholostomy, as well as a transperineal removal of the anal sphincter complex. Postoperative CEA levels are monitored for recurrence, as well as a colonoscopy performed at 6 and 12 months postoperatively, and then annually from then on. Anal carcinoma is almost always squamous cell carcinoma. Anal carcinoma is associated with the presence of HPV and genital or anal warts, female gender, men who have sex with men, and patients with HIV. There is also an association with smoking. Anal cancers above the dentate line are non-keratinizing squamous cell carcinomas, and if below the dentate line, they are keratinizing. Adenocarcinomas from the anal canal are rare and are treated similarly to rectal adenocarcinoma. Anal cancer typically presents with hematochezia, fullness or pain at the anus, or tenesmus. Diagnosis is made with biopsy, which can typically be performed on anoscopy. As with rectal cancer, staging should be performed with CT scan, particularly of the chest, endoscopic ultrasound, MRI, and PET-CT for evaluation of metastasis. Venous drainage is also important for anal cancer. Anal cancer above the dentate line drains to the portal system, therefore more likely metastasizing to the liver, and anal cancers below the dentate line drain into the caval system and thus are more likely to metastasize to the lungs. Chemoradiotherapy is the key treatment for anal squamous cell carcinoma, with surgery reserved for treatment-resistant or recurrent disease.
Kitty, oh no. No, Mittens! The damn cat! You leave those polypets alone! They're our friends!